My name is Alon. I'm from Israel, from the Sheba Medical Center. And today, in the next couple minutes, we'll be talking about indications and extent of central neck dissection. We have nothing to disclose. I do want to acknowledge Professor Talmi, who could not be here and who was supposed to give the talk this morning. Before I go into talk about the central neck, I think in the next 15 minutes you're going to hear me say a lot of maybes, possibly, could be, and I think I'm probably going to say those words for a certain period of time, the most I will in a lifetime, because I think this is such a debatable subject that there is really very difficulty in reaching a consensus in many of the issues we'll discuss in just a moment. So just for starters, I think it's important to make a distinction between the surgical versus the anatomical aspects of the central neck. So as you well know, level 6 boundaries are the carotid arteries laterally, the superior borders is the hyoid bone, inferiorly the sternal notch. And the inferior border of the surgical central compartment is actually defined as the innominate artery, which already includes what we define as level 7. When looking at the surgical aspect of the central neck and how we decide the extent of disease, here I quote 2 articles from our moderators here today that looked at the locations of nodes in the central neck and how they relate to our surgery, actually showing that above basically the cricoid cartilage, there are really no nodes that we need routinely to dissect out. So that is the difference between the surgical central neck and the anatomic central neck, which is bounded superiorly by the hyoid bone. In central neck dissection, when we talk about the extent of dissection, we're talking about the prelaryngeal, pretracheal, and paratracheal nodes, as well as the superior mediastinal nodes. In extended surgeries, when there is a therapeutic neck to be done, as you can see, there are other areas that we may at times rarely need to address, like the retropharyngeal nodes, retroesophageal, or the paralaryngopharyngeal nodes as well. So what are our attitudes towards central lymph node dissection? Well, we know there is a high rate of metastatic disease. You've heard that before. We know there's very low, on the other hand, mortality from well-differentiated thyroid cancer. But we need to acknowledge that there may be a potential of increased temporary or permanent complications. And approaches worldwide vary significantly from continent to continent, from country to country, and that needs to be acknowledged. Now, on top of that, to make our life even more difficult, there's such conflicting data and lack of randomized trials that really make it hard for us to make a decision at times as to what is best for our patients. So the 2009 ATA guidelines talk about central neck dissection for pathologic disease here. The recommendations is a rating of B. But when we look at prophylactic central neck dissection, and the recommendations are for tumors that are advanced T3, T4 tumors, we can see that this is only a C recommendation, just expert recommendation, which really puts us somewhat at a bind. When we look at different societies across the globe and their recommendations, again, you can see that there's a vast difference between the Japanese endocrine surgeon society with routine recommendations of central neck dissection versus the ACE that does not recommend central neck dissection prophylactically at all. And going back to the goals of treatment, we really need to keep in mind we're trying to improve the survival of our patients. In doing that, we're trying to decrease the rate of recurrence, which at most times that is what we're dealing with well-differentiated thyroid cancer. And with that, obviously minimizing morbidity for our patients. So indications like medullary cancer, large T3, T4 tumor, central neck disease, lateral neck disease, I think there's pretty much a consensus as to an indication for central neck dissection. But when we go into that gray zone of lymph nodes that are in the central neck outside those indications were really at a bind. So first of all, not all positive lymph nodes are created equal. In my mind, microscopic metastatic disease is not N-positive disease, as is a bulky 2-centimeter lymph node. So we use different tools to help us out here, and we use the ultrasound as a mainstay of our radiologic modality. But then we also count on our clinical judgment intraoperatively, whether it's by looking, by seeing, by palpating, and with the aid of our pathology colleagues in frozen section. But when we look at imaging in central nodes, we know the sensitivity and specificity are across the board. When we talk about ultrasound, it really is user-dependent, and you really need to take that into account when you critically review various studies. One paper out from MD Anderson that I thought should be acknowledged looked at, obviously with very good ultrasonographers dedicated to thyroid ultrasound, really relied on this tool to identify clinically relevant nodal disease in the central compartment. In their opinion, and what they showed is if their radiologist did not see anything that looked suspicious, probably even if there is something there, it probably is not clinically relevant. And I think that's a really important take-home message to be made. Now, intraoperative identification of suspicious central lymph nodes, there are 2 studies that I quote here that looked at the examination in the operating room. Well, what's our yield? A senior surgeon versus a fellow in training examining the same central neck. What is the yield of that examination in projecting the suspicious nodes? And the sensitivity and the specificity were very poor. The sensitivity increased when the size of the lymph node increased. Well, I think that's something that again bears into the whole aspect of the ultrasound that I made a point of just a moment ago. When the nodes are bulky and identifiable, that's probably a different disease than the microscopic disease that we're not able to appreciate in the operating room setting. So pros and cons of prophylactic neck dissection. The American Thyroid Association's Surgical Affairs Committee looked at what needs to be done in order to make to produce a study to look at these procedures, prophylactic central node dissection. And what they came up with was a staggering number. We would need to go over 7 years of a study, 4 years of enrollment, and 5 years of average follow-up with 5,480 patients to be enrolled to get adequate statistical power. Obviously, that is a task that is going to be very difficult to undertake. So the prones, if we look at the prones, lymph node mets in the central neck cannot be reliably identified during the procedure or ultrasound as mentioned. Central neck dissection can be performed safely in experienced hands, and reoperation for recurrence may harbor greater morbidity. It does improve the accuracy of staging, especially for those, if we look at the staging system above 45 years of age. It may show a decrease in post-op thyroglobulin levels. It may change the way we administer radioactive iodine, and it may affect overall recurrence rates and survivals. And as you notice, I'm saying may a lot of times because may is the crux here. When we look at the cons, you know, we're looking at maybe higher rates of complication, larger number of thyroidectomies performed by low-volume surgeons, as most of the time that is what occurs here in the United States. There's no hard evidence of lower recurrence and mortality rates, and despite high incidence of occult nodes, up to 90% in some studies, the incidence of post-treatment central neck recurrence is staggeringly small. So when we look at different systematic reviews and meta-analysis, as we don't have anything prospective, we can bear out some interesting data. Prophylactic central neck dissection may, in a third of patients, affect the way we treat them with radioactive iodine. It may reduce a recurrent disease. It may decrease the thyroglobulin levels. and it may lower the rate of reoperation in the central neck. But we would need to do about 20 prophylactic central neck dissections to prevent one central compartment reoperation, and I think that's even, I would probably quote even higher numbers. In some studies it's up to 30 patients per one central compartment reoperation, so I think that's, again, something to remember. When we look at recurrence and survival, this meta-analysis looked at 16 trials, over 3,000 patients, and when they compare the total thyroidectomy versus those that also had a prophylactic neck dissection, we did not see any higher risk of post-operative recurrence compared to the more aggressive so-called surgery with central neck dissection. And when we look at many papers that have been published throughout the years, there's, I just a few examples here. Obviously, we're not going to go over them. The idea is just to get an appreciation of, for every study that's against, we'll find another study that is for, making our life that much more complicated in deciding what to do. But I did choose to show this paper out of Memorial Sloan Kettering, published in December of 2013 in surgery, and I think it really makes a note, although I think Memorial is a unique scenario in terms of their team. What they did is they looked at patients that had total thyroidectomy done without known nodal status, and out of 275 patients in that group, over a 10-year, they had a 10-year disease-specific survival of 100%. There were only 4 patients that had uptake on whole body scans, and only 1 patient with structural recurrence with a rate of reoperation which was amazingly 0, which I think is really quite unique. So when we talk about thyroglobulin levels, that's something that wasn't available in the past. A lot of the studies didn't relate to thyroglobulin levels, and a lot of that information did not exist. We really still don't know what to do with thyroglobulin levels and how that changes our management. I'm sure many people are aggressively managed with post-op radioactive iodine because of levels of thyroglobulin that their treating physician is not happy with seeing on the blood test, and maybe over-treating them. But that's something that needs to be borne out. Complications, I won't spend much time on complications. Suffice to say that there's no statistical significance in most studies that I've seen with permanent hypocalcemia or vocal cord paralysis. There are indeed differences in transient hypoparathyroidism, up to 48% versus 20%, although it's really important to note that all these patients, or most of them, will recover. One point that people rarely talk about when it comes to central neck dissection, and this was a point brought up by Dr. Ptolemy, my colleague, is the expenditure. If we had to do prophylactic central neck dissections on all patients that present to us throughout the year, we'd probably be spending over $70 million extra on these procedures. And if we have to do surgery on those that recur, looking at the studies that look at the higher recurrence rates to about 12%, we're looking at a much lower number of just $17 million a year. So, and this is a point I think we really need to make noticed, and that's the experience of surgeons. Majority of thyroid surgeries in the United States are not done in centers of excellence. Most of them will do less than 10 thyroidectomies a year, and I think that comfort level is very important, and also the extent of surgery, and more so when there's recurrence, knowing to refer patients to centers of excellence to minimize complications, as complications are usually reported by large centers with high volume surgeons, and probably don't reflect most places. So finally, to sum it up, does central lymph node dissection decrease recurrence of disease-specific survival? Possibly. In patients with advanced primary tumors, probably so. With high-risk histology, probably so. Is post-operative radioactive iodine available in every country? That's not always the given case. So we really need to select our patients appropriately. Does it increase the risk of hypoparathyroidism and recurrent laryngeal nerve injury? Probably not. Probably in good hands, The transient hypocalcemia will still be there, but the long-term permanent results are going to be probably the same, again, in experienced hands in high-volume centers. Does reoperation in the sentinel compartment for recurrent papillary increase the risk? Well, we didn't go over this in this talk, but there's plenty of data to show that that does not increase the risk. So patients that recur and are referred to centers of excellence will probably not have a higher risk of injury to the recurrent laryngeal or permanent hypoparathyroidism in centers of excellence. And so food for thought. Not every neck metastasis is created equal. Micromets are not macromets, and we need to make that a point. What is the clinical relevance of micrometastasis with or without postoperative radioactive iodine therapy? The paper in Sloan really, puts it out there, not treating patients with radioactive iodine, following them for years without knowing their nodal status, seeing the excellent results. And we did not talk about BRAF, but my feeling is that in the future, molecular markers may have a significant role in, again, in our paradigm and decision-making process as to the extent of surgery. When a thing ceases to be a subject of controversy, it ceases to be a subject of interest. So luckily, this is controversial, and we still have a lot to talk about. Thank you.